And I'll talk briefly about what digital footprints means before I go on to talking about shopping data more broadly. So digital footprint data, as we talk about it, is kind of data that's collected about people every day as they go about their lives like normal from digital devices. So this can be stuff like electronic cards, like bank cards or supermarket cards, loyalty cards, that is, like Tesco Club card. Also from wearables like watches, smart rings, GPS from a phone, just anything that's kind of going on in the background collecting data about people. And some of them are like very obviously tangibly health related, for example, Garmin smartwatches. But some of them are kind of a bit looser, but we can link them to health, for example, social media or shopping data. And our lab mostly deals with shopping data, although there's some stuff going on with banking and other things I could talk about if need be. So the advantages of digital footprint data, the main one is how large scale this data gets very, very quickly. So even with one person shopping over maybe 10 years, you can end up with thousands or tens of thousands of items that they've purchased from a supermarket. And then if you have multiple people, it becomes into the hundreds of thousands of transactions very, very quickly, or even into the millions of people, depending how you collect data. The data is dynamic, which means it's continuous over time, but also depending on how you collect it, you can generally get data over very long periods of time, but also retrospectively. So you don't have to, if you want 10 years worth of loyalty card data, you don't have to wait 10 years. You can just find someone who's had a club card for 10 years and then get that, the data's already there, which is great. There's no participant burden really from this type of data, so it's already being collected, like I said, so it should just exist and people don't have to do anything active for you to collect it, which is very handy. And I think a main one is that a lot of survey data and sort of traditional methods are based on self-report, which means that they can be biased. Not that digital footprint data isn't biased, in different ways it is, but self-report data means that, for instance, if you're asking people about food, they might underreport how much alcohol they're consuming, overreport how much healthy food they're eating. So kind of using digital footprint data means that it's grounded in truth, which is really, really helpful. Also, I guess, when you're using data at scale, it can be quite representative. Not fully, but if you've got millions of people across the UK who have given supermarket data, it can be representative enough. There's a bit of demographic biases I'll get into in a bit, but broadly it can be representative. And then impact I'll talk about as well, but this kind of data can change how we evaluate policies or interventions or campaigns kind of at scale objectively, which is super useful. So shopping data specifically, shopping data as I'm talking about it refers to from loyalty cards, so from Tesco Club card, Nectar card, and we probably all have one, how can we not? They're really good for saving money these days. But basically, yeah, when you go and do your transaction, you scan your card, and the card retains everything that you've bought, and every time you scan it, it will keep a log of everything you've bought. So that's basically it. But this example is just to demonstrate the kind of things we could pick up about physical and mental health just in the one area of women's health, so over a year's period. So we might notice that a woman is buying kind of painkillers or sanitary products, other menstrual products, kind of on a cyclic basis, until the point that we see that they buy a pregnancy test, and then after that we might see changes in their nutrition, in supplements they buy. They might stop buying blue cheese or sushi or whatever. And then 9 months later, they start buying nappies, formula, and they also might buy kind of wellness solutions like lavender, flavored enhancements or whatever, or sleeping tablets. So this is just a very specific example of how you could use shopping data just to see kind of a woman's physical and mental health over a period. But we could look in kind of all sorts of dimensions, like nutrition is a huge one, but shopping data is also, depending what shop you use, many supermarkets have got pharmacies, so you can see health data, medications, alcohol, tobacco, lottery, petrol, all sorts of random things. It's not just food. There's a whole sort of range of categories of stuff that we can look at from this data. So in our lab, we're kind of doing a range of projects, and I'd say I'm involved in about 60% of these, so I can give it a go answering some of them in the breaks if people are interested. But I'm going to talk about 3 of them that I'm involved in, being public acceptability, self-medication, and sort of mapping the research landscape in this area. But yeah, there's also a lot going on in mental health, nutrition, predicting cancers, reproductive health, data linkage to other sources, which I will talk about briefly, to be fair. So firstly, when I joined the lab, which was about 14, 15 months ago, the first thing that my boss said was we should map the research landscape and see what research is taking place using shopping data for health at the moment. So we've done a scoping review over the last year, which has just been sent off to be published, and we found 44 studies, and this is across the world, not just the UK, that have used shopping data in some way, loyalty card data, to investigate health. And I'm not going to talk too much about the second and third points on this slide because I go into them again. But the 3 main questions that we had were, what type of data and products are people looking at? What health outcomes are they looking at? And what are the advantages and limitations of using loyalty cards for this way? So the type of data and products, I would say mostly 95% of the studies were using grocery data, which is probably unsurprising. And this would cover either like the entire set of grocery products, or it would be a subset. There were 8 studies looking at just fruit and veg. There was 1 looking at just dairy. There was a few looking at plant-based food specifically, and more specific groups like this. But there was also 3 looking at alcohol. There was 1 looking at tobacco. There was 4 looking at medication data. So the sort of small, growing research areas using shopping data. And importantly, 27 of the studies said which retailer they were working with, and 16 did not, which is a random point, but it does speak to the kind of resistance in industry to work on this kind of research. And that's for a few reasons, but mostly it comes down to sort of commercial interest and big headlines saying, horse meat in Tesco, found in lasagna, things like that. They don't want to be associated with any research that might look untoward or might say something bad about that supermarket. So advantages and limitations I'll talk about later, but health outcomes, we came up with this sort of visual for it, which is really fun. But broadly, there was, in the top right, there was maybe 20 studies looking at consumption patterns within specific populations, so like dietary diversity in Moscow or protein consumption in Finland. There was a huge number of studies using, say, millions of records, for millions of people, looking at these very specific questions, consumption during COVID-19, specifically of fish, things like that. And then relatedly, there was a good subset looking at specific nutrients or specific, protein or energy, or very specific nutrients like omega-3 or anthocyanins. So there's a big nutritional sort of standpoint for this research as well. Relatedly, there was a lot looking at the top there at socio-demographic inequalities. So this would be like looking at specific geographical regions, looking at different income, and seeing how do these affect what people are buying. And then the bottom left, relatedly, there was 10 or 11 studies looking at interventions. So these were kind of, some of them were like, how do we promote fruit and veg intake in low-income families, but others were kind of like, how does product placement or pricing affect what people buy? And then this was very much collaborating with supermarkets and using loyalty cards to track how these sort of interventions would change people's purchasing, mostly for sort of healthy food purchasing reasons, not for commercial. Interestingly, there's quite a few studies looking at government campaigns. So a few of these were in the UK, and these were looking at, the most prominent one was the sugar tax, which came in 5-10 years ago for sugary drinks, Coke and Pepsi kind of thing. And this was, the government worked with researchers to look in the millions kind of level at people, how their sugar intake changed after that tax, which is super interesting. And there were similar ones in kind of low salt campaigns and alcohol related legislation reform as well. And apart from that, there was, a few looking at self-medication practices, and a couple studies that were just validating whether loyalty card data does and says what we think it does. Another different study that I've been looking at, I could have made this more technical after seeing the other talks, but I'll talk about it if people want to. So this one was looking at laxative use for weight loss. So the idea being that people may, and the government have looked into this before and made changes to legislation based on this being fact, being that people at risk of eating disorders may have bought previously laxatives to kind of help with weight loss. So the idea of this paper was to see basically, how many do we have? 800,000 participants, and we have more than that in weight management, going on 1 million participants from a major UK pharmacy. I won't say who they are, but you can probably guess. And the idea was, do the patterns in weight management medications mirror those in laxative medications? So in the weight management plot, the kind of main thing that we see is that there's this spike in weight management products around the summer. And in the stimulants plot, there's harder to tell, but there is somewhat of a spike in the summer. And following on from this kind of exploratory plot, we did use regressions to use months as predictors, and then as the outcome variable was doses of laxatives purchased within these certain months. And yeah, we found some relationships within the summer specifically, that people were buying more stimulant laxatives for weight loss purposes. We also did look at sort of in the new year to see if people were buying more following the new year, thinking like new year, new me kind of thing, but they weren't so much anyway. Or if they were, it was kind of being masked a bit more by kind of overeating at Christmas and overconsumption, so harder to tell what was going on there. So the kind of limitations or problems of shopping data for health research, one of the main ones is that there's a lot of missing context about specifically shopping behaviors and also consumption behaviors. So we don't know if people consume what they've actually bought. We also don't know who they bought things for. We also don't know sort of, is there 4 people living in that house or just 1? So if they buy 4 pain meds, packets, is it all for them or is it for the whole family? So without surveys or sort of linkage in any way, it's really hard to attribute certain purchases to any sort of people. There's also similarly no health information. So in the case of the laxatives work, we don't know if anyone's got a diagnosed eating disorder. We don't know if they have any IBS or any kind of thing that might need to take laxatives. Biases in the data, as I said before, there are demographic biases. So loyalty card holders tend to be older women mostly for some reason. And also we're kind of missing people that shop in certain stores, like ethnic food stores. We're missing groups of people that shop in those. The data quality, I mean, the data is vast and it's huge, but people don't always scan their cards, so we are missing instances. I mean, I don't scan mine probably 80% of the time. We're missing huge instances of when people are being lazy or whatever. And then, shopping across stores. So if people are shopping in Tesco for fruit and veg, in Sainsbury's for something else, in Lidl for the middle aisle, whatever, we're missing, unless we can sort of aggregate all these different shops into one place, we're missing the comprehensive picture. And then ethical issues. I mean, I would say in our lab, when we're using data that people have consented to share with us, but in a lot of these studies, the data is probably taken in a way that's dicey and without people's consent necessarily, big companies sort of selling it on. So there are some ethical issues in the type of data use. And this is just a point about some public acceptability work that we did. So we did just have a 6-month exhibit at We the Curious, which is a science centre down at Bristol Harbourside, which was super nice. And we had this kind of shop set up with lots of plastic food, plastic baskets, etc. And the idea was that children were supposed to come in with their shopping basket, fill it up with lots of food, and then they'd do some sort of activities around the room that would get them thinking, what can we tell about you from the kind of things you've put in your basket? So if they filled it up with medications or meal deals or whatever, what can we tell about you? Can we tell that you're a vegetarian? Can we tell that you've got this health issue, etc.? And the exhibit did have closer to 35,000, I've now learned, visitors, which is fantastic, including 16,000 children, which is really, really cool. We had 3 Meet the Researcher events where we went in person, and some of these were in the evening or the weekends, and we kind of had specific events around data linkage or around specific topics where we spoke with people about their concerns about this type of data, and also kind of got ideas about what research they thought was interesting, which was really useful. And we are using some of that now to shape what we're doing. So for example, lots of people came up with stuff about veganism, plant-based diets, which I'm using to write into my grants, along with quotes from people about what they were interested in seeing. So that was super useful. And I guess this is ongoing work, basically. This is kind of the direction of where we're going, is looking at how we can link shopping data into longitudinal population studies. So this has happened already in ALSPAC, which is the longitudinal study based in Bristol. It's had around 14,000 participants originally, and fewer now, but it's still ongoing, basically collecting health and clinical measures frequently from people. And in the last year, we've linked, doesn't sound like very many now that I've said all these high numbers, but 250 participants have got their shopping data linked into the ALSPAC database now, which is fantastic. It covers 650,000 items over a 10-year period. So we're looking at what kind of studies we can do. Obviously, we have all of this ground truth data about those people's health conditions over the last 30 years. So we can do a lot more linkage now between tangible health problems or social problem, anything really, and what we're seeing in their shopping data. And of course, we also know their household compositions. We know how old they are. We know all these demographic things. So basically what I'm getting at is that longitudinal studies and linkage into these is a huge solution for a lot of the biases and problems that I already outlined. So briefly, we kind of laid out this 4-stage process for how this linkage should take place. The first being public acceptability. Anya has done huge amounts of work on engaging with the ALSPAC participants and finding out how this linkage would be acceptable to them, basically. From then, the data linkage, which can mean and does mean usually talking to the supermarket and getting them to send us the data. And then the third stage is evaluating the quality of the data. Does it say what we think it does? Is there any missing data? Is there any sampling biases, etc.? And the last stage is then making the data accessible for research in a secure and ethically compliant way. And I will say that the ALSPAC linked data is available to researchers. And the aim is to keep doing these linkages now in other cohort studies throughout the country, and also expanding onto other digital footprints data. So the next stage in ALSPAC is banking data, and they are doing wearables as far as I know in ALSPAC. So that don't know why the slide moved. But yeah, expanding linkages. And yeah, this is the Digital Footprints Lab. There's 8 of us, 5 postdocs. Anya is the PI as PhD student. And yeah, so do feel free to check out our LinkedIn or the website or anything to see what else we're working on. I've only covered like 2 or 3 projects, but we're covering a huge range, which is really exciting. Thank you.